Hello, I'm Alexis Beatty, and I'll be the moderator for this session. Good morning to those of you on the West Coast of the United States like me, and good afternoon to others who are in other areas. We have an exciting session for you today about digital cardiac rehabilitation. I'm going to do a very brief intro while people are gathering, and then we'll launch into a series of questions for our panel here. And at the end of this session, you don't want to leave early because there's a very exciting demo that we'll be showing you at the end of the session. So I'm going to start out just by doing a brief intro on digital cardiac rehab and where we might be seeing ourselves in 2021 and beyond. First, I do have a couple of disclosures that I was formerly employed by Apple and do receive research support from the NIH now. So for those of you who aren't deeply embedded in the cardiac rehab space, cardiac rehab is a beneficial, guideline recommended, multidisciplinary and multi-component program that focuses on 5 health behaviors: physical activity, healthy eating, tobacco cessation, medication adherence, and psychosocial wellness. And historically, cardiac rehab had been delivered in cardiac rehab centers through usually 36 sessions, 3 sessions a week for 12 weeks. But we'll hear today about some of the innovations that people have been engaging in cardiac rehab. And a lot of the terminology is evolving to think not necessarily about where cardiac rehab is delivered, since we're delivering it in many different locations, but to thinking about delivering this core piece of cardiac rehab in many different ways. So it's all cardiac rehab. We're just delivering it in multiple different ways now. And so we think about synchronous or in-person cardiac rehab, similar to the traditional center-based cardiac rehab. Now, and especially during the pandemic, we have synchronous virtual cardiac rehab where people are in a different location than the cardiac rehab staff, but are exercising and communicating over two-way audio-visual communication. And then there are asynchronous and remote forms of cardiac rehab where the person exercises on their own. They communicate with their cardiac rehab staff over the phone or through digital tools, and things are monitored somewhat remotely by cardiac rehab staff, though they may still have telephone or video visits with their patients. And so we're in this new world where cardiac rehab isn't tethered to a center, and we have multiple different ways where we can deliver cardiac rehab. And one patient may participate only in-person. One patient may participate only in asynchronous or remote, or a patient may participate using all of these different cardiac rehab delivery modalities. So it truly is a new era of cardiac rehab. And so with this exciting time that we have, I'd like to open it up to our panel. I think we've seen a lot of changes over the last year and a half with the COVID-19 pandemic. And certainly it has changed some things about the future of digital cardiac rehab. But I think there are also some things about the future of digital cardiac rehab that haven't changed because of the pandemic. And so thinking about these two things, what has changed and what hasn't changed, I'm going to open it up to our panel to begin the discussion. And so maybe we'll first start with Eleanor. I think you particularly can talk about some of the things that maybe haven't changed.
So I just want to talk a little bit about my background in cardiac rehab. For almost 30 years, I was at Kaiser Permanente, Northern California, and my hospital was a teaching hospital of Stanford University, and Stanford had no physical bricks and mortar cardiac rehab. So in 1988, Bob DeBusk developed a research program with Nancy Houston Miller and situated it at my hospital, Kaiser Santa Clara, for a virtual cardiac rehab. And this was extremely successful, had more than 85% participation, which has continued for 30 years. And I became the head of it and regionalized it to 23 medical centers. So from rural California with Hispanic farm workers all the way to the crunchy people in the wine country of Santa Rosa, we had every ethnicity, every socioeconomic slice, all doing remote cardiac rehab after a cardiac event. And the outcomes were outstanding, such that the risk of having a cardiac event, if you were a Kaiser Permanente member, was 30% less than the rest of the state of California. And this was all with remote cardiac rehab. So going into the digital age, we have Epic as the main electronic medical record in Northern California among all the different facilities, including Stanford, UCSF, Sutter, Kaiser. So we can all share information. So we were able to bring it online into the computer age. Now, at this time, what happened with COVID is all of the bricks and mortar centers across the country in March of 2020 had to shut down. So there was no essential physical cardiac rehab across the country. And the digital or remote cardiac rehab programs, such as Seth Martin's group's going to discuss at the end of the program with the Corey app, or I work for Moving Analytics, which took the Stanford program and put it into a commercial digital format, were not really up and running across the country in great volumes. So there was a crisis in that the physical programs could not do cardiac rehab. So this is going to be a great solution for the future. And I am in favor of having hybrid programs where a center which can service perhaps 15 to 30% of people who are willing to come to a center, but they can then service the other 70% with a remote program, one of which we're going to hear about at the end of the session. And the only other thing I wanted to add is for 2021, Medicare CMS has now made this a HEDIS quality measure for patients to undergo cardiac rehab, because we all know what it does for outcomes. Thank you.
Yeah, Seth and Francoise, do you guys want to speak too about kind of give us the preview of what you might talk about with Corey and the avenues that this opens up?
Sure, I can kick it off. Thank you, Alexis. It's always following Eleanor. She has such a rich depth of understanding of this challenge and problem. And we're definitely, I would say, the newer generation of thinkers around how are we going to solve this problem, to your point, and what we all understand is getting more patients access, particularly those that are underserved and where health equity is an issue and oftentimes are left behind in the traditional model. So what we hope to highlight at the end of this session is walking through a case example of how a patient who might otherwise not have received services is going to go through and experience the virtual cardiac rehab hybrid version along with us here on our virtual session. So we'll walk through that patient's experience. And I think it will highlight, both to your original question, Alexis, what is new and what is within the traditional system that still needs to be there. And one thing we'll highlight is that there's no replacement for seeing the patient and evaluating them for safety, for participation, even though we have thresholds that have been our standards for patients participating that are low to moderate risk, that have an EF that's greater than 40%, no lethal arrhythmias, et cetera. There still needs to be some level of a human touch point and a clinical touch point to really engage these patients, get them started, and make sure that it's safe for their participation. So I think that part of the traditional center-based care is so critical. but I think we're going to highlight how we can bring in now all these new tools that a lot of patients have with them already that we're going to now activate to be part of cardiac rehab. Thank you.
Yeah, Alexis, I can add, maybe amplify a little bit. First of all, I just want to thank you for including us. Thank you and Alexis and Eleanor, who have been just tremendous leaders in this field and inspiring us, really, setting up the chance to scale up digital programs to really reach patients, to provide that access like Francois highlighted. I want to thank everyone who's joining us, in this important discussion, because this is going to take a lot of teamwork, I think, to make this happen. And so I think just the spirit of collaboration we have within this digital cardiac rehab community is super important, because ultimately this is about getting this to our patients. What if not, first of all, what if we could get cardiac rehab, which we know is, once patients get in there, they become inspired, they have better outcomes following, prevention. What if we could get all the patients who qualify to get in? And then what if in the future we could even expand it to more patients who we think could benefit but don't meet current traditional criteria, like patients with atrial fibrillation, or even in the primary prevention setting of atherosclerotic cardiovascular disease? Cardiac rehab is such a great way to organize the tools that we know work. And there's just so many more people that could benefit, but we're not anywhere close to providing the access that we need. So I feel like that's what is changing now, is the time is right. We have the technologies are there. The time is right to connect the dots and really scale up all the great benefits of cardiac rehab that Eleanor has already been successful scaling up regionally, and just scale it up further. The tools are there, and we just need to make it happen. And it's not an easy challenge, but the benefits will be tremendous.
We got one question through the chat that I'd actually like to hear Evian comment on, because I think you have some insights into what we can do here. So cardiac rehab is, when we do it in the center, there's a lot of group camaraderie between the patients. And so there's a lot of, social engagement and peer engagement that helps the patients to get and stay motivated. What can we learn from the mental health world that can help us when we're delivering digital cardiac rehab?
Oh, thanks, Alexis. A great question and great summary of what hasn't changed. I'd like to maybe address that question about one factor that I think is changing, and that is stress. So, and before I do, I just want to just acknowledge CI who have really been crucial in underpinning this Think Heart program that we're doing that is focused on this issue. Essentially, what we've seen, so when I set up the first standardized and integrative database on the brain, what we saw is that stress was such a critical gateway to all of mental health. So we had about 1 million data sets, and then we developed it online, and we have about 1 million people now who've used it. And what we saw, Alexis, was that the granularity of the specific engagement and retention parameters for stress, and I'm also a fellow of the American Institute of Stress, and it's the same dynamic where I think everyone's moving to, that the days of should lists, you should do this, and you should sleep better, and you should exercise more, is great. I mean, it's of course critical, but it is not what rewires the brain into a new habit. So the granularity of, in the case I'm suggesting stress, to answer the question broadly, is the sixth potential guideline to your really terrific list at the beginning. So what we've seen with mental health is that giving people should lists is just not effective in creating habits, new habit behavior change. The granularity is critical. Are they negatively biased? Are they positively biased? Are they introverts? Are they extroverts? Are they ready to change? I mean, all stuff everyone knows, like the biggest gap is, of course, between knowing and doing. So that's, I'd say, the broad answer is that the biggest gap is knowing and doing. So, okay, easy to say. What's changed? Well, a couple of things. Firstly, the focus, by actually saying, you've got 50,000 thoughts a day. How do you change one of them? Like specifically, what is your strategy? And how do you help people find that? Number one. Number two, and probably the last point I'll make that exemplifies, I suppose, where we're going, is biometrics. Like being able to continually measure heart rate variability, for example. One of our collaborators, Julian Thayer, published in 2019 the first index for heart rate variability as a metric for cardiac risk. And, it's less than 25 milliseconds RMSSD. So these kinds of granular metrics and publications are the basis where we want to take the database we developed on the brain and expand it to cardiac rehab. My PhD, actually, ironically, was on a young medical student, was on serum lipids, body shape, and heart disease. And it took a long time to now see that the platitudes about brain body are becoming much more solid. And the lessons of mental health around stress are being deployed in a very granular way. And so my answer, I'd say, Alexis, is that the detailed way to elucidate and start getting detailed proof points around stress, but equally stress and eating and all the other metrics that are in cardiac rehab, I think, is what is changing. So that's the sort of my broad and hopefully a little bit detailed exemplar with heart rate variability of what I think is new.
Yeah, there certainly are a lot of opportunities for monitoring a large variety of metrics. And even in traditional cardiac rehab, we do actually monitor a fairly large variety of metrics. Here's maybe a thought-provoking question. Should we view that monitoring of all of these metrics through a wearable device or through patient report or through things that we can measure in the center? Are those essential core components of digital delivery of cardiac rehab? Or are those just tools that are maybe optional? What do you think? Can you do this, without all of the biometrics, or do you need them?
Maybe I can just add one more example about why, of course, you can do it without them. And I think, Illinois data is like amazing. And so that's great. But I think that in terms of what's changing, I'll give you one other example why the biometrics are more than just nice to have. Depression. When you look at the relationship between, and coming back to the first question as well, just to finish it off, between depression and cardiac disease, and then the fact that we're just about to publish this, that increased heart rate variability can be induced by some of the antidepressants. So when you have reduced heart rate variability, when you have reduced heart rate variability as a crucial index of risk for cardiac disease, but also recovery for both stress and hugely linked to depression. When you start looking at that clinical interconnectedness, one of the biggest lessons that we saw from our database on mental health is that those interconnections are huge drivers of outcome. And I think it's more than just a nice to have. I think they help with treatment decisions. I think they help with tracking who is getting better, who's staying the same, who's getting worse. And most importantly, they give the granularity as to what's working and why ultimately. So I think it's becoming more than a nice to have with that kind of context of very specific, clinically targeted questions and support sort of issues.
Yeah, Alexis, thanks, Avion, excellent feedback there. And thanks for this thought-provoking question. I think it's really at the crux of a lot of the technologies that we're starting to build around virtual cardiac rehab. And it's an important question to answer. I have two main points here that I want to just present to the group. One is that our patients are becoming more consumers of health data, whether they're getting it through their Epic MyChart and they're already aware of their lipid panel and their blood pressure and their heart rate that they've been tracking through a log, or they have an Apple Watch and they've already detected they have AFib before they see you coming into the clinic, or that they understand that you've set guidelines for them in the clinic to reach, like a blood pressure goal of 130/80, or keeping that heart rate between 50 to 70. And a lot of our patients will ask us, well, how are we going to track that? How are we going to know if we only see you in the clinic and we only get that snapshot of data? And I think that has been an important part of where there's going to be success in this program, in that as we talk through the case that we'll present at the end of the session, I'll share with you that important teachable moment with the patient, and that moment of empowerment where the patient's able to use their own biometric feedback to understand why they're taking that statin therapy to get their cholesterol level under 70, why they're taking lisinopril to get that blood pressure below 130/80, and sort of connecting the dots, I think, as Seth had mentioned earlier. So I think it's something that reinforces, and it also helps to empower our patients to make the right decisions, the tough decisions, to stay away from that extra salt load on Thanksgiving, to maybe remind themselves to take medications every day so they don't miss it. And so I think it's an important therapeutic benefit. And I think it's a driver both from the clinical side, but also from the patient side, to be more informed and participatory in their care.
And Eleanor, what in the old version of the program, what did you measure?
Yeah, so what we would do, and what they still do, is for 6 months, you're in the program and you measure your exercise sessions, your blood pressure, your lipid panel, hemoglobin A1C, and then using 2 scores, GAD4 and PHQ-9, for anxiety and for depression. And and then of course, smoking cessation. At the end of the program, less than 5% of patients are still smoking. So more than 95% are not smoking. And we do include marijuana smoking because that's become a bigger issue as patients think that it's medical marijuana, therefore it must be good. And more than 85% had blood pressure less than 140/90, which was, the minimum blood pressure control. From that, they go into something called PHASE, Prevent Heart Attack and Stroke Every Day, which has a handshake with the cardiac secondary prevention program. And that includes also diabetics, people with chronic kidney disease, and people with stroke, as well as people who graduated from cardiac rehab. And that gives an ongoing list to each primary care provider of their patients who completed cardiac rehab every week, of what has their last blood pressure been, what has their last LDL been, what has their last hemoglobin A1C been, and are they picking up and adherent to their medications. And on that list, if someone has fallen out, then the primary care caregiver just gives a checklist to their medical assistant, who calls all the individual patients, like, you don't seem to be picking up your meds, your LDL's out of control, and they get direct feedback after they've finished the cardiac rehab program. So the elements that I think are most critically important are hemoglobin A1C, if anyone is pre-diabetic or diabetic, lipid panel, blood pressure, and exercise, minutes per week. Now, this was before wearables came in. I think the wearables are fantastic. There's not only Apple, there's Fitbit Sense, there's KardioMobile. There are many ways to monitor the patient. And I think it's really great. And I advise my patients in the clinic to try to keep their exercise heart rates in that zone of 75 to 85% of max. So I usually give them, which is always given in cardiac rehab, an exercise prescription. So an exercise prescription to exercise so many minutes per day to a relative perceived exertional scale of 13 out of 20, which is short of breath, but can still talk, and to keep their heart rate in that zone. So that's the kind of advice we give in cardiac rehab, and that's the kind of advice I give in the clinic. So I'm really positive on home monitoring. That's my thing.
Seth, go ahead and give it a shot here. I think one of the other questions that's relevant for this discussion too is about the value. Is the value there for doing this?
Yeah. Well, if I could just pick up on some of what Eleanor was saying, because she sparked at least a couple kind of thoughts that I think are key for us to consider here moving forward. So first of all, number one, I mean, as I listened to Eleanor speak of these elements, I mean, it's impressive how much cardiac rehab brings together. It's really a comprehensive program. And so I think, and in fact, Eleanor, Francoise, and myself and a big team co-published a systematic review on digital cardiac rehab. And it really found that a lot of the solutions that have been published so far have really had a narrow focus on the physical activity exercise component, but the other core components are really being missed. And I think as we move forward, and that's part of what you'll see in Francoise's presentation later, is that we really need to embrace the comprehensiveness of cardiac rehab. That's where the historical benefits are, and things like A1C, LDL cholesterol, and so forth. That's part of the program here, and so I just want us to kind of keep that kind of front and center. The other kind of aspects of this in terms of value, I think and I think Mark Galati brought up some questions along those lines, as well as sort of the camaraderie of patients moving forward. Yeah, I mean, in terms of the value, when you prevent expensive procedures and hospitalizations and so forth that are not costing $100 or $1,000, but tens of thousands of dollars, possibly hundreds of thousands of dollars, the value can be, I think, accrued really quickly. And so when we think about the cost of a wearable or something, that could end up being a drop in the bucket compared to the cost that could be saved. We have some initial experience in this area with our MyCore trial of CORI, and we do have a cost effectiveness analysis published in Medical Care. And here we see large amounts of cost savings that can be accrued from this approach of connecting with patients with digital technology. This was an early iteration of our programs before we've gotten into further developing our virtual cardiac rehab program through the HA's Health Tech and Innovation Network. But this initial experience with MyCore, which is the first 30 days after heart attack, we're seeing very positive results from an economic standpoint. So I'd be curious to hear the thoughts of the rest of the panel. But I think at a high level, we could still invest in some technology here. And I think it's important to have loaner programs like we've done to make this accessible to everyone. And even if you do that, I think the potential is not just for it to be cost effective, but in fact for it to be cost saving.
Yeah, and I think one important point within this is that today, during the public health emergency, hospitals and health systems and physicians' offices can be reimbursed for providing virtual cardiac rehabilitation. And that was not the case prior to the COVID-19 public health emergency, except if you practiced in an integrated health system like Kaiser or the VA. But during the public health emergency, people can get reimbursement for virtual cardiac rehabilitation. It is still uncertain whether those public health emergency allowances will be continued after the public health emergency is over. I think we're all kind of devotees of this. And so I'm sure we would all vote for continuing that payments for virtual cardiac rehab after the public health emergency. So I think now is our time to sort of make that pitch, So what I think, Seth, you were alluding to this just now, like about what is the pitch, what is the argument for why we should be continuing this. We can be speaking maybe to health policy leaders, but I think we also need to be speaking to hospitals and health systems who are often on the hook for a lot of these costs, for readmissions, and for caring for patients who may be in an accountable care organization. So how do we make the pitch to policy leaders and hospitals and health systems that digital cardiac rehab and virtual approaches to delivering cardiac rehab are worth their time and effort and cost.
Well, that's a pitch I'm making every day. So I think you have to go to the payers, because if you go to Blue Cross Blue Shield, the different health insurance, it becomes a no-brainer for them, because they pay more if people get more sick. So it's to their advantage to keep people well. But it just has to be made evident to them that cardiac rehab, virtual or hybrid or bricks and mortar, keeps people well. I think as far as CMS and Medicare, they're definitely going to be continuing it for the rural environments where they never could get to a bricks and mortar. Now, whether they continue it for the urban environments, it's not clear to me. But I think that if the commercial payers can start to pay for it and realize how important it is, that CMS might see that and go along. So, so that's what I see. I mean, you already see, if you're in a place that's an HMO, like the VA effectively is, or Kaiser Permanente, they absolutely embraced it from the beginning, because it prevents people from utilization because they stay well. So I think it's going to be a no-brainer for the commercial payers if it can be made evident to them. So Seth, you've got to go out there and go talk to them.
That's right. And I'm bringing Francoise with me, because nobody's better at pitching than Francoise. I think it's the pitch and the data, continuing to accumulate the data that we can bring forth to make it a no-brainer decision.
I would add one other group to that, to payers. Of course, we work with payers quite closely, but also groups like IBM. We've just been adopted by IBM for the mental health side to go to all vets and DOD. So when you've got these groups that have the distribution, it's another pathway that is sort of not quite direct to payers, but direct to those few groups like IBM who have the massive distribution. So that's just another. And they are looking for kind of and a kind of flex, kind of innovative in the way they're thinking about, and they're not stuck in old ways. They're innovative in what they're thinking about, sort of the possibilities of the ROIs for integration, basically. So that's just another option we're thinking about. Took a while, takes years to get those decisions done, but when it does, it's like a battleship moving. It's quite extraordinary to watch, actually.
I think on this topic, one thing that's really important to mention as well, I was actually having a meeting yesterday with a industry government affairs leader, and we talked about the fact that the Office of Minority Health is a really powerful and interested body of government that would be very interested in seeing that cardiac rehab, unfortunately, has a huge amount of patients that are underserved and minority individuals who are not getting the same access as the rest of our community. And from a population health standpoint, these types of both leveraging digital health, especially in an era of COVID where we know that we need to be able to rely on this technology to help when 70 to 80% of our centers shut down if we have another crisis like this or something new happens. We need to be prepared. And so I think that there's an opportunity to leverage CMS, but also working along health disparities and solving that problem along with leveraging technology. And I absolutely agree that bringing industry into this to help us to really solve this quickly and to work effectively to figure out what's the value proposition. Can we do pilots that are going to help to really answer these questions, get the data that we need to start scaling this and getting this to more patients?
Quick frame, and then I think this is a great segue to the next topic that I wanted to get into with all of you. So cardiac rehab is underused in the United States, even when we're talking about bricks and mortar programs. So only about 25% of people who are eligible for cardiac rehab actually attend for sort of ischemic heart disease diagnoses. And then there's been recent publications just within the last couple of weeks that it's more like 10% for heart failure patients. And even if every bricks and mortar program were to be at full capacity and then some, we would still only be able to deliver cardiac rehab to about half of the country. And then, as has been pointed out by several of the speakers, there's huge disparities, right? So women are less likely to be referred or go. Racial and ethnic minorities are less likely to be referred or go to cardiac rehab. And then we have these areas in the country that are cardiac rehab deserts, and a lot of them are rural, but one of them is actually San Francisco. So San Francisco only has like 2 cardiac rehab programs for the entire population of the city, which is not enough. And so, I think there's 2 issues here with digital cardiac rehab. A lot of us see the promise for digital tools for addressing a lot of these disparities that we see and improving access. But there are also challenges to using digital tools for achieving health equity. So how can we harness this to really address the challenges, whether it's health literacy, digital literacy, broadband access, what are the challenges we need to overcome to use digital cardiac rehab to achieve health equity?
Alexis, maybe I kick us off here. This is exactly the focus of our current AHA-funded MTech Center. And I think there's obviously multiple important ingredients here. One thing I want to highlight, though, is we need to bring the patients into the process of building these programs from the start. That's what Nino Isakadze, who's our fantastic AHA ESIFRIN fellow, is leading our human-centered design sessions. And so patients, their family, caregivers are involved in making sure we're thinking through all those components that we need to think through, not just making a beautiful app, but making an app that is intuitive to use, but also that they have access to the right technologies. We've had to create loaner programs so that we can make sure everyone can access the program. But then it's not just about the access to the technology, it's also about the coaching that's needed. Some people get it within a few minutes, some people take more than an hour. And so personalizing that coaching that's involved. And also our patients have highlighted that high quality education is really, really critical. They are currently often going to Google or YouTube to find the answers that they need to their questions. And so bringing high quality content into the app for education and making sure that it's at the right health literacy level. So we've worked with the head of patient education for our hospital, Francoise and myself, who really taught us some key principles to make sure that all the education we were bringing in was accessible to our patients. And so I feel like one of the key elements here is we need to make sure we're building solutions that meet the end users. And so it's really starting with their needs and working backwards. Of course, there's core components of cardiac rehab that we need to make sure are in there, but the way that it's delivered could vary greatly depending on how the solutions are built. And so that's the type of approach we're trying to take is really starting with our end users and working backwards.
This is Eleanor. So in my work at Kaiser Permanente, I work directly with health education, and we tried to aim actually for a 5th to 8th grade literacy level in our patient education materials, which we put both online, accessible to the community, not just to Kaiser Permanente members. You can go to kp.org and read all the stuff I wrote for years and years about heart disease. And we also translated it, again, at a 5th to 8th grade literacy into Chinese and Spanish, which are 2 of the major languages in the Bay Area. We will, at some point, we do need Vietnamese, but I have to say Chinese and Spanish were the primary ones that we have translated into. So I do think you need to make it also accessible in other languages and a lower literacy level. And and accessible to all. So the program that we developed there, we actually gave to the community clinics that do Medicaid throughout California. So now that I'm at Stanford and I see the Medicaid, which we call Medi-Cal in California, patients come to Stanford for their cardiac consultation, I see my own programs staring back at me because they're on all the right meds. They're on a statin, they're on an aspirin, they're on an ACE or ARB. They're on everything they're supposed to be because the community clinics embraced the program of essential medications.
Just add one other thing, Alexa said, where mental health might have something to offer in this as an example. And that is this huge access issue that you've highlighted, which is, of course, not just in cardiac, it's there for addiction, it's there for mental health issues. And I suppose one of the examples that we've been looking at is CBT, cognitive behavior therapy, where it was mostly done in person and very inexpensive and time consuming and effective. But the increasing evidence that online CBT is just as effective as face-to-face in some cases, like people who don't have severe depression, for example. So being able to elucidate those proof points that Seth alluded to earlier, and then be clear about what is the absolutely unambiguous differentiation of digital rehab, and then deploy those pieces on scale, I think is a good tip of the spear to really get right as a group, the community, really resolve that beyond the generality. So I think there's huge scope for that to bridge that gap.
There's one other thing I wanted to bring up on diversity and inclusion is the hypertension program that Kaiser Permanente did to reduce stroke over time. Spearheaded by Joel Handler and Mark Jaffe. And what they found, because there's a large African-American community in the East Bay of the Bay Area, and what they found was that instituting guidelines and having direct patient contact and being very persistent about these goals with that population, with the health education materials at the appropriate literacy level, they were able to achieve equity in blood pressure control across ethnicities within the medical group and reduce the risk of stroke, which is really critical in the African-American community. So I think the idea of really adhering to guidelines and pressing on it, in this manner, in a global way, really helps.
Francoise, I saw you try to unmute there.
Yeah, thank you. I just want to, from a community level, remind us that the patient returns to their everyday life. And I think building partnerships in our community, whether it's YMCA or whether it's with our neighborhood pharmacy or with our health centers, to really understand that cardiac rehab is it's going to build a habit and a lifestyle that needs to be supported by the community moving forward, and to offload some of the challenges that might exist within trying to provide everything within the hospital system. It's important to really start identifying that and growing the care coordination that's required to really support the patient all the way through a heart healthy, as Eleanor is mentioning, those guideline directed medical guidelines, really making that an everyday thing. And I think we have to just be acknowledging that patients might have those social determinants of health or community issues. And we need to start addressing that as part of this comprehensive program. In Corey, we actually try to identify early on if patients have trouble accessing medication, transportation, or feel that they need caregiver support during this process. Because along the lines, I know Evion's been focusing on mental health. It's so critical that we think about the person and everything that's surrounding them in really making those goals we're giving them actionable. They need to be supported in a holistic and comprehensive way. So just taking into account community, social determinants of health, and really addressing them along with our rehab support.
One of the reflections I'm having right now on this session is we're talking about digital cardiac rehab. So we're talking about technology, right? But we've spent a lot of time actually talking about people. and people being patients, but we've also talked about a little bit caregivers, healthcare providers, doctors, nurses, exercise physiologists, and the community. And so it does sort of beg the question, when we're talking about digital cardiac rehab, are we talking about something that is completely automated and delivered from an app? Or do we think that these connections and people are still part of the equation?
I want to talk about that right away. So part of these programs, like the Stanford program that Kaiser took on, that Moving Analytics is commercializing, part of the essential part of that is always the care manager. In this case, it's usually a registered nurse. It could be an exercise physiologist, but a registered nurse can do the comprehensive part in terms of the stress management assessment, the medication adherence, the assessment of the blood pressure and the community. They have a lot of social education in their training. So the care manager takes on perhaps 200 to 400 patients a year. And they have a direct relationship with the patients that they're managing. So even though it's a digital remote program, the patient has their care manager, their person that they connect with, who then has a direct connection with their cardiologist or their cardiology group to pass on if something isn't going wrong. So they actually, it's not just a digital app on a phone. It's a personal connection through the digital app to a care manager that cares about them and can assess their symptoms and make sure they get the appropriate care. Seth, you want to talk about that?
Yeah, I'd love to elaborate on that. I completely agree with you. I mean, I think this people component is critical. I imagine the consensus here is not that we're just going to download an app onto a phone and then it goes from there and it's wishing them luck to do well. These human touch points will be really critical. So the exercise physiologist, the RN, it really is a wonderful opportunity with cardiac rehab to bring the multidisciplinary team together to support the patient. But the technology approach does allow us to get into that more continuous care model and to do things more efficiently so that they could be scaled up. And I think that that's kind of, to me, the way this will look in the future. And it'll help us as clinicians on the clinical side of the team prioritize who may need help, now. And that came up in one of the earlier health tech sessions earlier this morning. But cardiac rehab is, I think, a program that's kind of ahead of its time in the way that it really was providing this more longitudinal care with multiple touch points and building that social connectedness. And I think we need to continue to, respect what's been successful in the past and not allow technology to just totally take us to something that doesn't look anything like it looked before.
Alexis, could I just add one other proof point about community? And one of the reasons we work with Shelley Carson at Harvard on this, and it's just astonishing how obvious about how powerful the data is of peer feedback. And once there's nothing more powerful, and you can have all the doctors in the world telling people what to do. There's very complicated dynamics in that. But peer feedback, there's nothing more powerful. And I think that's a crucial variable to keep expanding on.
Yeah, and I will say, a lot of programs have done this differently, and during the pandemic even. And our program at UCSF has turned basically into an entirely hybrid program, where we deliver cardiac rehab in whatever way sort of meets the patient's needs, whether it's virtual, telephone, remote, in person. For the patients who are participating mostly virtually, we actually have weekly basically Zoom sessions. We call them wellness sessions, for people to continue to have that peer engagement, even though they're not having the center experience. And so they get both the reinforcement from their cardiac rehab providers, whether it's through one-on-one interactions or chat. And then they also get the peer interactions through these weekly group Zoom sessions. I don't know, have you guys incorporated any peer motivation into Corey?
Francois, do you want to tackle that? Yeah, I mean, I think the peer interaction is critical. Totally agree. Corey has we've explored different options for that. Our cardiac rehab center does have those Zoom educational sessions, so they can participate in those. We've looked at sort of building chat or Facebook type groups for people to come together. I think those tend to work best when it's like a patient-led thing. And I think that's where, as we look into the future, some programs have done a really great job bringing on alumni of their program. Like cardiac rehab is kind of like a college, and then you develop some folks who are really enthusiastic graduates of the program who then can participate. So that's the direction that we're going, to try to build out that camaraderie. But I think there's a lot of opportunity here. I don't know if you want to add anything, Francois.
Yeah, I totally agree. That social networking, peers. We also see a lot of value making this a family affair. So bring this into sort of a companion experience, so that you're tracking not just how you're doing, but the family's going to take a walk. Who's doing better with their steps? That sort of friendly cooperability among peers, among family, we think is very powerful, and we're working on that as well.
All right, I'm going to take one last sort of question for the group here, and then we'll dive into the Corey demo. So I think the last question I'm going to start with is, okay, you are a cardiac rehab program or a hospital or a health system or somebody who wants to start doing digital, virtual, remote cardiac rehab. How can you do it? What do you do?
There are several commercial programs, and their system can contact, either Corey, Moving Analytics, there are a couple other ones, and have them come and do a demo virtually for your health system to see how it's going to integrate with your bricks and mortar program. And there are many successful hybrid programs happening across the country. Highmark is the private group around Pittsburgh, just like Sutter would be in the Bay Area. And they've instituted a hybrid program with about 15 to 20% of people coming to bricks and mortar, but the other 70% to 80% using a mobile app with a care manager. So I think if you have a large group, or if you have a health system, they can have different vendors come and on Zoom and give virtual presentations, and then let the health system decide what makes the most financial sense for their institution. But I think there are solutions, which we're going to see a demo of, available, and that's how you get started. I think as an individual, it's too difficult because you need a certain bolus of patients. Francois, you want to say something?
Yeah, I think that was perfect, Eleanor. First of all, congratulations to that person that's interested, because they're, leading the future here. We need to be ready for it. I think getting that understanding of the culture, it really starts with knowing that the exercise physiologist, the team, the director of cardiac rehab, getting those key stakeholders organized around this idea, getting the administrator who's going to find the budget around supporting the program, and then really being prepared to go in and speak with one of these teams, whether it's Moving Analytics, Channel Health, talking with our team. It's so important to just see what's out there, but have everyone on your team be prepared to make that transition or offer that program and be excited, because I think it's the culture that makes it successful And that makes a big difference.
Right. And I could say, I've gone into multiple places across the country now. And if you do not have the team on board, they will work against you, because they will go to the patients and they will say, well, we have our center, and we do have this other alternative, but it's not as good. And you cannot have people do that, because then you just lose patients along the way and they end up not participating in anything. So you have to make sure everyone's on board that we're going to be a hybrid program before you actually launch, because I've seen individuals just not have a stake in it and undermine it.
I'll also point out too that there have been a number of great publications that have come out during the pandemic recently too, that are focused on implementation of new approaches to cardiac rehabilitation. And if I can provide links to all of those for folks as well. There are now a lot of resources out there, whether it's YouTube videos or curated collections of education materials. There's a lot more available to the general community now than there was 5 years ago. So
I'm going to say one more thing, because we have a very wonderful, active Department of Public Health leader, Sarah Cody, here in Santa Clara County. And there is a great worry that in the winter, we're going to have a surge the way we had last winter. I was on call at the very peak, the second week in January. Every other patient I saw in the hospital had COVID. And there is a concern that we're going to have a peak like that this winter. So these bricks and mortar programs might be shutting down yet again. So now's the time to look at alternatives before we end up with another 6 months lost of cardiac rehab for our patients.
All right, well, with that, I'm going to close our session discussion here so that we can see the Corey demo. This has been a great discussion. I've really appreciated getting to hear all of your perspectives on this really exciting area. I love that I work in digital cardiac rehab and get to spend a lot of my time thinking about this, because it's an exciting new era, and it really does help us to meet patients where they are and provide them with the support that they need to help them achieve their cardiovascular health goals. And so with that, I'm going to turn it over to Francoise, who's going to lead us through the Corey demo.
Great. Thank you so much, Alexis. And thanks for those comments too of enthusiasm. This is an incredibly exciting field to be a part of and a really big impact on our patients. So our mission, and I think I share this for everyone, not just Corey Health, is to give every person the opportunity to benefit from cardiac rehab participation. I want to walk you through a patient example and journey so that you can really understand what it's like to be a part of the Corey Cardiac Rehab program. Derek's a 52-year-old firefighter. He unfortunately suffered a heart attack and was referred to cardiac rehab, but much as we discussed, he had many barriers to going to a center-based program. In fact, getting time off from work was impossible for him at the firehouse. The center was actually more than an hour away from his house, and the copay, the gas to get over to his cardiac rehab center, and then adding on top of that, his just additional costs of being off work were just too much for him. And unfortunately, he wasn't able to participate until now, until we've offered a solution where really putting patients and giving them cardiac rehab sources and resources at home is making a big difference. So Corey uses a smartphone application that I'll be walking you through that is cooperative with a smart watch and a blood pressure monitor so that patients can really start engaging in guideline-directed care and supervised exercise while they're at home. They also have a chance to get a resistance band to do extra exercises and a pill box to help keep them on track with their meds. All the health data from Corey flows to the clinician dashboard, and it works as a portal for that Corey coach to be able to keep that patient engaged, supported, and encouraged throughout their experience in virtual cardiac rehab. It's a 12-week program where we start by engaging our patients. We get them started with the technology. We really focus on making sure that there's virtual support for them when they need it. And then we coordinate their care with community resources. We keep them empowered and engaged in the program. And we help this to be something that becomes a lifelong heart healthy life. It starts by identifying what patients would actually benefit from the program and be eligible. So we have an Epic-based trigger as well as a data filter that really allows us to identify who's meeting the ICD-10 codes. Like, for example, they had an aortic valve replacement, they had an MI, heart failure with reduced EF, that would allow us to know that they'd be eligible for this program. We use inclusion criteria using best practices from the AACVPR that based on age, heart function, and lack of any lethal arrhythmias like VT or VF. And then, of course, whether they have technology or they're interested in using a loaner device in the program. And then we start getting them into the program and getting started. The first thing, of course, is meeting them. So whether we're meeting them in the hospital after they've had an MI, for example, with Derek, he's had an MI and we're introducing the program to him for the first time. When he's ready to get started, we get his email address, and through an email, he's able to download Corey onto his phone securely through the App Store or through Google Play. Then what we do is we have our patients go and do one center-based session where they can get a health assessment to make sure that they're safe to participate and they're low to moderate risk for doing this exercise at home. It's also a great opportunity to set those exercise goals and prescriptions so they know exactly what they need to do as they're heading home to start the program. Let me show you what it's like to get started with Corey. First, what we do is we get that patient onboarded, whether it's iOS or Android. They start setting up their account by enabling notifications so that those calendar reminders and those other reminders come up easily on their phone. Then they start personalizing the experience. They put their photo in. They're also including risk factors like if they're a smoker. And then we make sure to address social determinants of health. So here we ask about if they have trouble affording medications, transportation, or other issues that we can address early on. Now we get them comfortable with the technology and the wearables. So we have tutorials that help walk through how to use a blood pressure cuff, whether it's iHealth or Omron, we support multiple blood pressure devices. Then we want them to get comfortable with the smartwatch. What we have them do is show that they can easily click off and track their medications on their smartwatch. We make sure they feel comfortable with developing that digital health literacy. We also show them where their heart rate can be tracked and what a safe range is for their heart rate. We also show them how to do workouts and set that through their watch. So whether they're doing an outdoor walk, for example, they can get started and get that going easily. So once they've got the application and they have their wearables, they're ready to start the program. We have a Corey coach who provides health coaching and keeps the patient on track. So for example, Derek's going to start his first exercise opportunity, and he's going to be coached in order to make sure that he's safe and excited about what he's going to be doing. The coach is also there to help answer questions, whether they're about how to use the application or just about questions regarding his management. He's empowered through this health coaching, and it's really quite an important part of his experience. Let me show you an example of what virtual support is like. Here's an example where we have a structured exercise session at home. You can see Derek scrolling through and he's going to take a walk. He first answers the complete to the safe to participate checklist to make sure he's not having any symptoms and his vitals are in a good range. Then he clicks getting started. And you can see as he's about to get started here, he can have an option to actually do this with an American Heart Association trainer. So this is a really cool session where he's going to walk with Leslie and he's going to get the opportunity to get tips on heart health and follow this along with a smartwatch. From our dashboard, we're able to follow and see what Derek has been doing in terms of his exercises. The exercise chart gives us an at-a-glance view of what types of exercises that he's been doing throughout the program. And there's a way to take a deeper dive by clicking on one of these exercise histories to really get the details of what he's been doing with each exercise session. Duration, frequency, and pre and post vitals are part of understanding what his workouts have been and how he's been doing to provide feedback. That's an example of virtual support during a structured exercise session. Now, it's so important when Derek's going through recovery after a heart attack to coordinate care, whether it's making sure he's on guideline-directed medications and keeping up with that, following up with cardiology primary care, making sure he knows how to check his blood pressure, or keeping up with his exercise and healthy lifestyle. Derek has a lot of care coordination, and we're here to help through that. Let me show you an example of how we help him go through care coordination. So let's get started with vitals tracking. He's going to be using a blood pressure cuff at home to keep track of his blood pressure. And here what we do is we walk through step by step how to take a valid blood pressure, everything from resting for 5 minutes to making sure that the arm's at the level of the heart, to actually holding off and not talking while they hit the start button. Once they go through this process and they hit collect a blood pressure, it automatically syncs with Corey. Then they can enter their heart rate or have the heart rate flow through their smartwatch. We also track mood, so we can keep track of how they're feeling. And then we also have the ability to either sync with a scale or enter the weight manually. So patients at a glance get an idea of how they're doing from heart rate to blood pressure, weight, and step and activity count. Then importantly, we keep them on track with their medications. So aspirin, their statin, Plavix, lisinopril, these are key medications after suffering a heart attack that they need to be watching out for. And not only tracks, but it keeps them informed on why they're taking these medications and common side effects. And it's all written at the 6th grade level. Now, as we flip and we focus from the clinician or the coach's view, we get a look at a glance at how our patients are doing at 7 days, 14 days, or 30 days. And this gives us a really accurate estimate of how they've been doing during that recovery time. And is there anything that we could get better on in terms of guideline-directed medical care and goals? And so as we look down through heart rate, blood pressure, and steps, our eyes might see that his blood pressure has been trending in an elevated range in the 150s to 160s. We know from guideline goal, we're trying to achieve less than 130 over 80. So this actionable insight is a way for us to be able to work on adjusting lifestyle like DASH diet and maybe addressing that medication management at his next clinic visit. We also can take a look at steps and see how his activity goal is going, making sure that we're able to positively reinforce and then also give him opportunities for improvement. Now, as we take a look at his medications, we can see that overall, he's been around less than 80% over 3 days, 7 days, 2 weeks, and a month, just looking at this brief review. And as someone who has had a stent after a heart attack, there's some concern because it looks as though he hasn't been 100% adherent to his DAPT. He's also missed his statin on several days. And so again, for our guideline goals, we can explore how to address barriers to DAPT, as well as his atorvastatin, as well as blood pressure medication control. Now we can flip to education as well, or we can jump in and see how he's doing with his own health report. So what's really great is that patients have a chance to click on their own key cardiovascular metrics and share this report with their primary care doctor, cardiologist, or other healthcare provider. So what we were seeing on our review screen as a clinician can also be shared by the patient to their own care team for coordination. Now let's empower our patients to get with the guidelines. At this point, Derek's been with the program for a few weeks now, and this is an opportunity to use the data that we're getting from our wearables, from the information that we're gleaning from the dashboard, and really build on it. So for Derek, who's had a heart attack, we focused in on LDL-C reduction. And when he takes a look at Corey, he can see that his range is 84, he's at 84, a range really being in the higher, a little slightly elevated, trying to get him less than 70. This is a point where our Corey coach is able to work one-on-one with Derek and make a suggestion that in addition to staying with his statin, we can get him to the American Heart Association Heart Kitchen to help improve his diet. So Derek had the opportunity to go to his community heart kitchen and take his family and learn how to cook heart-healthy diets. Let's take another example here of how we empower our patients. So here's another view of where we can really dive in and provide additional metrics for our patients to get an example of how they're doing. We can give them kudos for good work on keeping their blood pressure goals below 130/80, the heart rate that's within that safe range that we're aiming for, and good weight control, as well as keeping track of their mood. So this is a way that they can get closer insight. Here you can see where Derek's checking, and look, all of a sudden his cholesterol is at a better range, and it's been in a better range since he got that feedback from his Corey coach and started going to the heart kitchen. So this is an example, again, of how we can really work on providing that specific feedback and empowerment. We also have really top of the line education, whether it's an article or video that inspires our patients to improve their diet, nutrition. If they're smokers, we give them actionable resources like 1-800-QUIT-NOW so that they can actually get those free resources and quit smoking. For diabetes, lipid, and blood pressure management, we do everything we can to help inspire them to do well at recording their vitals and keeping up with that goal of less than 130/80. And with our education, we love to give our patients kudos and positive feedback. If they complete all the learning, their heart fills with gold, and we're able to give that reinforcement that they're doing an awesome job. We can also see on the dashboard if there is room for improvement. For example, if they're less than 80 or 90%, we might make suggestions about how they can improve their learning. We also have the opportunity to have precise education that's really prescribed to our patients based on their comorbidities and health risk factors. So this is an example of how we empower our patients to be more engaged in their care. This is the exciting phase where really Derek has been engaged in the program for 36 sessions, and it's his graduation from the program. But we really view this as a way to maintain heart healthy routines and stay engaged and connected. For example, we encourage our patients to join us. This is the most recent Maryland Heart Walk this year with our Corey and Johns Hopkins team, and at the Heart Kitchen, where we've cooked meals and helped prepare food for our patients and for our community. So these are great opportunities to graduate and also maintain heart healthy lifestyle within our community. We want to scale this type of innovation to provide patients and adults here in the US equitable access to cardiac rehab services anytime and anywhere. Like was mentioned earlier by Alexis, we live in a country where there's deserts. If you can see all this light blue, this is where there are no centers. But we envision that with virtual cardiac rehab, hybrid cardiac rehab, we can build more opportunities for patients to receive services and reach everyone around the globe. Now imagine if instead of those 10 to 20% of patients that are now receiving those services, if we're to empower and change and innovate our program so that patients like Derek, who would have been left out of getting cardiac rehab, are now served. Imagine patients like him, and we can reach patients across the country who need our valuable cardiac rehab services by doing this innovative approach. I want to thank you for your attention. I want to thank Dr. Martin, Dr. Ali, Dr. Matthews, and Dr. Azakazde for all of their incredible work and effort in this project. Thank you so much.
Thank you, Francoise. That was a great demonstration of the capabilities of Corey and all of the potential that we have for using digital cardiac rehab to improve access and health equity in delivery of cardiac rehabilitation. This is, like I said before, it's a really exciting space to be in, and I'm really hopeful for the future. And I think this is a great group of experienced and knowledgeable panelists. And if you have questions for any of us, please feel free to reach out. We're deeply invested in making this work.